Board Bombs.
Hi, and thank you for joining us on an episode of EM Board Bombs. Dr. Briggs is already laughing at me, but this is my first introduction to an episode, so hold your judgments. We have an exciting topic today that everyone loves, that no one wants to see, but guess what? It's coming to an ED near you.
Whether you like it or not. Whether you like it or not. This is a prime package you can't return. So, EM Board Bombs, podcast you know and love. Dr. Wasiski-Kun, thanks for being with us today, as always. The trio of success. Wasiski-Kun, myself, and Dr. Hussain. As usual, Dr. Hussain is not here. He's off doing important things. You know, kissing babies, shaking hands.
In Europe.
Probably in Europe, yeah.
Wearing Armani.
I don't even want to picture that. Anyway, for each 15-20 minute episode, of course, EM Board Bombs, we give the people what they want, Blue Collar Podcast. And we are known for our quick wit and our amazing amount of information we give you in a span of such a short amount of time. Sometimes we go over that 20 minutes, but man, is it juicy. It's interesting. You get a lot of great content for boards, but not just boards, for life. We tell you some very interesting perspectives that you need to know. And we just simplify it, don't we? We make it really nice and easy. This is not one of those podcasts you listen to and get all the nerdy facts. Nope. We tell you what you need to know. We'll just tell you straight up not to worry about that on this podcast. Like, you're never going to see that. Don't worry about it. And that's cool. Sometimes you need to listen to something like that. Man, do we have something entertaining for you today? This one is going to be a two-parter already. We can tell you right now. We are talking about the very scary, nightmarish problem of a precipitous delivery in your emergency department. I already know a lot of people hit the brakes in their car. If they're listening in the car, they turned around and walked inside the house, turned off the podcast.
Starting their day over.
Locked themselves in a dark room. Hyperventilated. Yeah. It's so funny. You know, we see so many awful things, so many scary things that average doctors really don't see regularly. And for some reason, any pregnant patient of any type just absolutely makes everyone shiver in the emergency department, nurses included. The most veteran, you know, older nurses that still smoke. You know, exactly. Everyone knows that nurse, charge nurse who still chain smokes outside the ED in the trauma bay. That nurse can handle anything in the ED, except you mention, hey, there's a lady coming about to deliver. They'll be like, nope, I'm going to go smoke.
Time for my break. I think it's the combination of like the two things that we like are the most nervous about: pregnant patients and a newborn infant. And now,
yeah, no, exactly. Two
here's
patients.
Both of them. Like I love like the way that when a patient's yelling or like alarms going off, people like don't really look around that much. But if you hear like an infant cry, immediately everyone's like, huh?
Yeah. The best part in RED is like, what are they doing here?
Oh, same. Yeah. Because we're right across from the children's hospital and they're like,
yeah. Can they turn around?
So let's talk about it.
Let's talk about it. Let's talk about it. Let me read this stem to you. And actually, I want you to read it.
Okay. All right. You ready?
I'm ready.
All right. A 24-year-old female presents to your ED with abdominal cramping. You enter the room, and as you palpate her rotund abdomen, she tells you she might be pregnant. She endorses cramping and pain that's progressively worsening over the past hour, and you ask how many weeks she thinks she is, and she says a lot. Her boyfriend at the bedside says more than 30 for sure. She's had no prenatal care. In fact, she tells you that she's had quite the birthing plan that she discovered on the internet, and she looks at her boyfriend. He hands you a laminated card. It's highlighted in multiple colors that correlate with music choices and essential oils. You ask if the patient's been having contractions, and she replies, my birth method refers to them as pressure waves, but yes, I have, and they're more frequent. Meanwhile, you are placing an ultrasound probe on the patient's abdomen, and you note a single gestational fetus in the vertex presentation. You don't see a low-lying placenta. Her vitals are normal, and now she's endorsing severe cramping pain close together. On your gloved exam, you can palpate the fetal head. You alert your charge nurse, who just got back from her smoke break, and OB-GYN is called. They're currently not at the hospital, and they're pretty far away.
And your worst nightmares are realized.
Yeah, and it's happened.
It's happened.
And your single coverage.
And it's July 1 and you're a new attending.
Yep. And what of the following is the most accurate statement regarding the care of this patient? Your options here are A, immediate transfer to a hospital with OB-GYN in-house coverage. B, magnesium infusion started. C, Trendelenburg position to buy time for OB to arrive. Or D, if no monitoring is available, fetal heart rate should be checked every 5 to 10 minutes. But before we get to the right answer, can we talk about EM Rapid Bombs?
We sure can.
EM Rapid Bombs is our subscription podcast. It's short, 2 to 3 minute episodes, very focused on a single topic, and you can subscribe to get them delivered directly to whatever your preferred streaming app is a couple times a week. And you also get spaced repetition email. It's a great way to work, short doses of learning into your daily routine. You can sign up on our website.
Check it out. EM Rapid Bombs. Yeah, just go to emboardbombs.com. It's like a one-click sign-up process. We've noticed a flurry of sign-ups recently, and definitely know it's coming to July, which means new interns wanting to study more. Fantastic way to study your intern year, to motivate yourself, to get that 2 to 4 minute episode daily dose. And also those new attendings, because there's something coming up in the fall that you may have forgotten about. It's called your boards. So it's also good to get a head start listening now.
Yep.
Cool. Also want to give a shout out to EM News, our sponsor, only sponsor. Check out emnews.com. Really love their content. And they got editorials of every type, up-to-date articles on talks, on social emergency medicine, new up-to-date technology, and of course, clinical controversies and just new emerging technologies. So check that out, emnews.com. It's free if you're any type of emergency medicine clinician. All right, so we're talking about precipitous delivery today, and this is one of those things that is so scary as any type of emergency doctor, because humbly we know we don't regularly do this. Now, we will say that hundreds of deliveries per year occur in the United States outside the labor and delivery suite. They occur in the emergency department. Hundreds of them occur in emergency departments every year. In the majority of cases, everything goes perfectly fine, and mother and baby have good outcomes, and everything kind of runs on automatic cruise control. Like, this is obviously a natural occurring process for thousands of years. And it's interesting to think that for tens of thousands of years, we delivered babies outside the hospital. Now, the critics and pessimists out there will say, yes, but thousands died. And this is true. This is a true statement.
Yeah.
And maternal morbidity, mortality, infant morbidity, mortality was quite substantial. But thankfully today we have modern technologies, good guidelines, evidence-based medicine to help us through this scary process. So this review we're doing here, we have a review guide on the website already, study guides. You can download it and just read it if you want. And we're covering the highlights of that to get you through this scary process, covering some of the board relevant material. But honestly, there is such limited board relevance of this topic that we just thought, hey, this is just a fun topic. And this is just something that I wanted to cover. I know Dr. Brzezinski-Kuhn wanted to cover, because as an emergency doctor, you always want to face your fears. You always want to know, what am I deficient in? What do I don't see enough of that if I saw it, I need to, work automatically on this process. I don't have time to think it and look it up. Get into some definitions here, some annoying board pearls you just have to know. For some reason, I was tested on this a lot. I don't know why I kept seeing this come up in review questions, but you just have to know it.
A precipitous delivery is when labor has been going on for no more than 3 hours from the onset of regular contractions. And then the cardinal movements are tested all the time. That's one thing that you probably did get drilled into as a med student, but if not, just think about these. The head flexion and descent, the internal rotation, the neck extension, the external rotation, and then delivery of the anterior shoulder before delivery of the posterior shoulder. That can be hard to picture in your head verbally as someone's telling you. So if you have to quickly look at some pictures or a video, do that. practice it with your small dog or whatever stuffed animal you carry around with you regularly.
Yes.
Whatever works.
Smart. Very smart. So what's the first step here?
Well, the first step is we should probably tell them the answer to the question.
Oh, shoot. Let's go through those choices again. So choice A was immediate transfer to a hospital with OBGYN in-house coverage. That was incorrect. So this patient is within minutes of delivering. You palpate a fetal head. This patient's close to crowning. This is not a patient that is suitable for an EMS transfer.
As much as you may wish you could push the head back in, you can't don't do that just because you're scared.
Can't reverse it. Can't reverse nature. Choice B was magnesium infusion. That is not indicated in a patient without preeclampsia. So this patient, we didn't give you any indication she had this. We said normal vitals. So we didn't hint at the blood pressure being elevated. We didn't hint of other things going on, like a fever or a tachycardia or edema in the hands or feet or proteinuria, whatever. None of that stuff was mentioned. So those aren't routinely indicated. Choice C was a complete joke. We were just trying to appeal to your emotions of wanting to fight gravity.
Can't undo it.
Trendelenburg position to buy time for OB. I made that one up. So you can't do that either. And then choice D was obviously correct. We'll get to that. You want to do fetal heart tone monitoring. If you don't have TOCO in your ED, those elastic band monitors they put on pregnant patients, which some, a lot of EDs probably don't have those. Then you just do sporadic fetal heart monitoring with Doppler if you can, or ultrasound if you have it. Cool. So now that we got that done, what's the first step?
Yeah. So the first step, which we did do in this question stem by getting our charge nurse, is calling for help. You may want to call for transfer, but in this case, when the mother is in active labor, you're stuck. You have to manage this situation. So calling for help is obvious to anybody who's not an obstetrician, but don't also forget to call pediatrics for the baby or whoever you have that covers that, family medicine.
Everyone's heart just sank because they remembered about I have to manage the baby when the mother is
over. You're about to have 2 patients.
Yeah, fantastic.
And then you want to get a rapid OB-GYN history from the patient. So in this case, the patient's history was that she's had no prenatal care, but anything you can ask about them is a normal pregnancy. Do you know anything abnormal about it? Like, do you know where your placenta is? When was your last ultrasound? You know, anything like that may help you understand issues the mother's had. And I actually recently had a colleague who does like single coverage rural medicine tell me that his last precipitous delivery, the mother comes in and says, "Oh, yeah, I had prenatal care." And he was like, "Oh, yeah, who was it?" And she was like, "Well, it was like you. I saw you a couple months ago. You told me I was pregnant."
Oh, my God. That is such a classic emergency medicine story. That's so funny.
So Dr. Briggs, you want to tell us about gestational age?
Yes. So the gestational age is something you should try to do the best you can to estimate. This is so important. It's like a blood pressure for a cardiologist, for the OB doctor. So if only the estimated due date or the last menstrual cycle is available, it's the worst case scenario. You can use a calculator to find the current age. Every one of these things is like an empty calc or very Googleable. It's my first time saying that word. I think it is a word. So let's say you're unable to talk to the patient due to the clinical condition, due to a language barrier. That definitely is a possibility. You want to palpate the abdomen for the uterine fundus. For example, if you measure using your fingertip 24 centimeters above the pubic symphysis at the uterine fundus, the pregnancy is about 24 weeks in gestational age. This is not that accurate, but if you're in a tight crunch, tight squeeze, and the patient literally has no idea where they're at gestational age, this method works best. Now, body habitus, of course, can limit this, and so do what you can. Let's simplify this even more. So if you're in the boat of, I don't want to think about this that much, I'm going to be so frantic, I'm going to be sweating. What's that quote from the House of God? If you walk into a patient, first check the patient's pulse, then check your own.
Check your own.
That's deep. So simplifying this more, if palpable above the umbilicus, the uterine fundus is palpable above the umbilicus, then the pregnancy is very likely greater than 20 weeks. The gestational age is critical here because it prepares you how to anticipate the delivery of the neonate will go. Like when the neonate comes out, it's going to be, oh shoot, I'm going to have to intubate. Oh my God, whole different podcast. Yeah. Or am I going to have to do other things? Or it's greater than 30 something weeks, 35 weeks. I have a very likely chance of delivering this neonate and everything perfectly well is going to happen. Good chance of good outcomes. So these are important questions to ask. Actually, just one question of calculating a rough gestational age. Now, the next thing is going to be this gravidity and parity. Gravidity, G's and P's. That's going to be the number of prior pregnancies and then the offspring of those pregnancies. Greater than 20 weeks, 0 days, summarized here. So remember this cool mnemonic. Now, what mnemonic did you learn for this? What did you learn?
This Florida
this
Power
one?
and Light.
Okay,
yeah.
good. Okay. Because my father, to those of you that are dear listeners to the podcast, you may know my father's an MFM, maternal fetal medicine specialist. And he taught me this when I was, even before med school. And he taught me this one. I thought it was like old school. And I thought there must be some new, like, cool way to remember this. Maybe there's like a new one that people are using now. But it's encouraging to know and nostalgic to know that the mnemonic my father taught me is still the one being taught in medical school now, or wherever we are nationally. So that's wonderful. I'd like to say that it was his mnemonic. I'm just kidding. So the G's and P's. Florida Power and Light, FPAL, the first letters of those words, Florida Power and Light. I actually literally still say this mnemonic at work when I'm calculating the G's and P's on a patient, because I have to remind myself the order to put those numbers. So full term, preterm, abortions, and living, Florida Power and Light. Okay?
And remember, Sweet. It can be confusing if they've had twins, because it's one pregnancy,
Very
but
confusing.
then you'll have more than. So if the math doesn't add up, that might be why.
And also ectopic pregnancies don't count. Yeah. Really gets confusing. So don't worry about that. Just keep it really simple here.
In this situation, you're really just like, is this a multip patient or not? How fast?
Exactly. Because if it's a multip patient, it's going to deliver in 5 seconds.
Yeah. It might already be out by the time you finish asking this question.
2 pushes. Okay. Then you're going to ask about medical and obstetric problems. Why don't you get into that?
Yeah. So you want to ask about like previous C-sections. You think about like a classical incision that has an increased risk of rupture, any kind of pregnancy fetal anomalies. Does the mom have any bleeding issues? Has she had preeclampsia? Does she have gestational or chronic hypertension? And then anything that would concern you for risk factors for placental abruption as well. And then ask about a penicillin allergy, like a real penicillin allergy, because you do want to think about GBS prophylaxis.
Right, for sure. Speaking of GBS prophylaxis, why don't you get into some of the details? But I want to preface by saying this gets a little bit nerdy. This will probably be the most nerdy part of the podcast. So you can listen to it, but it's not really going to affect too much what you're going to do in the ED.
Yeah. So if you think the patient is less than 37 weeks gestational age and she has no like anaphylaxis, you can give 5 million units of penicillin G immediately for GBS prophylaxis.
5 million.
5 million units. You're obviously not going to like swab her and test it, and like you're just do it. If she's
send it.
Actually legitimately allergic to penicillins, give 2 grams of Ansef.
Mm-hmm.
You know, that's like really.
We're not sponsored by Ansef.
but that's cute because that's like something that ortho would get right in a delivery.
That's very.
You'd be like,
cute.
What antibiotics to give? They'd be like, cefazolin. And they get it right.
Okay, you said it that way.
These those would have to be redosed, but at least you're giving the first one now. If the patient is sure of their due date, they're definitely more than 37 weeks, or you have it in the EMR, then antibiotics are unnecessary. Mm-hmm. Remember that any fever on assessment, so if they come in with a fever, that could be an intraamniotic infection, and that is completely different antibiotics.
I'm just laughing at how like incredibly complex and awful that could be. Like you have a pregnant woman, like she's crowning, and the nurse is like, by the way, her temperature's 103. We're like, oh,
by the way,
God.
She's meeting sepsis criteria. Do you want me to collect cultures?
Yeah.
Oh my God.
You're delivering the patient, and the sepsis, officers come by the room. Why haven't you drawn your second lactate yet?
Get a documentation.
Hands are down there in the perineum. Yeah, we're going to ding you. Medicare is going to rescind your funding for this hospital that you haven't appropriately resuscitated this patient.
Amazing.
All right. So what's the next thing you're going to do besides all these questions?
On the route of antibiotics,
right.
Rupture of membranes, and that, PROM, PPROM, ROM, we all know about the ROM. So if the patient has ruptured their membranes, and this has happened like 18 hours ago, so she comes in and she like tried the at-home essential oil whale noises birthing plan, and it was a day ago that her water broke, start antibiotics right away because there's high risk of group B strep and other types of polymicrobial infections happening there.
And hopefully the women will be able to tell you this was the case.
Yeah.
Hopefully. Gush of water sensation, urinating sensation,
usually
soiling
not
clothes.
subtle.
It's usually not subtle. Correct. Cool. All right. So back to the mom. Rapid assessment here. You're checking the blood pressure. This is so critical because this is where you could diagnose preeclampsia, right? And then you would be giving MAG due to the high morbidity and mortality to the mom. So remember, we did an episode on preeclampsia before, and I believe we have some rapid bombs on it too. And there's a handout on the website, so we got you covered. Systolic blood pressure greater than 140 or diastolic blood pressure greater than 90 alone should just raise your suspicion enough that you probably just go ahead and just give IV magnesium. It's like no harm in doing it. Just go and do it. Further check, of course, for asking about a history of proteinuria, if they've been diagnosed with this, or any other weird symptoms that shouldn't play here. Severe headaches, blurry visions, sorry, all the visions that are blurry. Chest pain, epigastric pain, right upper quadrant pain, sure, okay. Not just ham cramping and I'm contracting, or having pressure waves, as our patient described in the question. Ask the patient if they had hand or facial edema. Leg edema is typical in a lot of pregnant patients. And then if any elevated blood pressure is present with one of these things I just said, they're going to need IV magnesium. But again, if you're unsure of it, just do it. There's no harm in giving IV magnesium to these patients, especially if they're at risk. It's a 6-gram loading dose, very high, not your typical 2-gram dose you're giving for any other condition. And you're giving over 20 minutes, very fast, followed by 2-gram per hour redose, essentially. Hopefully you don't have to deal with it that long. Okay, so on to ultrasound. Let's talk about that here. What are we doing? We mentioned the question. There's like 3 top things you have to do with your bedside ultrasound. And we say bedside because you just don't have time to have a sonographer come to bedside and do this. So you're on your own here. And thankfully, I don't want to go on a limb and say this. I'm trying not to sound, what's the word, privileged at my trauma center ED that I have an ultrasound. But I'm assuming, I don't know if this is a bad assumption. You have a lot of friends in rural medicine. I do too. That there is some sort of ultrasound machine available in most emergency departments in this country now, even rural EDs. There just is. Even if it's not that good of an ultrasound, there's at least some type of ultrasound somewhere. If it's even a regional center, a critical access hospital, there might be an OB ultrasound down the hall or something you could steal. I mean, there is one, hopefully, somewhere. Again, there's going to be a flurry of emails we're going to get saying, I don't have an ultrasound. How dare you assume? I'm like, well, I'm assuming you do. Then go buy a portable one. They're very cheap.
Yeah, they're really not that bad anymore. Use your CME.
Mm-hmm.
You want to do your bedside ultrasound to determine the lay of the fetus. Like in this question stem, the fetus was vertex. That is what you are hoping you will find. Head down. It's also something that's like not very subtle. You can pretty much tell if the head is down or not. And then the other thing is if the patient doesn't know anything, the location of the placenta, because previa can be identified on ultrasound
rapidly.
Pull up a few pictures of that just to refresh it in your mind what that looks like.
So what if you have a placental previa?
Yeah, then you do need to do what you can to stop the delivery, because that's going to be a really bad situation for the patient. That's an absolute contraindication to a vaginal delivery.
No.
That patient needs a stet C-section.
Of course.
And you want to do the ultrasound before you do a vaginal exam to feel for dilation, just in case there's a previa and you don't want to discover that by poking it.
Trial and error. Yeah, exactly right. So ultrasound first in all cases. Any pregnant woman, precipitous delivery, you're doing an ultrasound immediately.
Yeah.
Hopefully you have one. And you're looking at what? Vertex presentation, where the placenta lies, and then, of course, fetal heart tones. If you're there, you might as well just look at it.
Yeah. That could be your first of 5 minutes. I once had to fly a patient who was in labor, and you obviously can't hear heart tones on a helicopter. So every 5 minutes, I was just putting the ultrasound back on her and collecting more heart tones.
That's crazy. That's a cool story. That's just throwing your weight around right there. When I fly pregnant patients that are about to deliver, here I am just working at my trauma center. Yeah, it's fantastic. What else are you going to do on exam? You're okay. So you're feeling for presence of a fetal head. That's
Yeah.
cervical opening, which is called crowning. What else?
Which hopefully, if you're feeling something coming through the cervix, it is
Yes.
the fetal head, because feeling like a foot or
Oh my
an
God.
umbilical cord is a bad situation.
Yeah.
You don't want those.
Yeah.
Cord prolapse is another contraindication to delivery. That's like I think the question that everyone knows the answer to. Elevate the presenting part.
Ride the bed. That's what they call it,
Yeah.
OB, when I was in residency. My last case ever as a resident on doing my required EM delivery rotation was walked in the room, we're about to deliver, and the OB, like first year intern, like, palpates, does a cervical check, and then feels the cord prolapse, feels a cord, and she's like, "We got a cord prolapse," and then like everything happened so quick, it was so incredible, like their response rate, and then she like, sure enough, like crouched on the bed, put her hand up there, and elevated the presenting part, the fetal head, and shielding the umbilical cord from compressing, and she rode the bed, and she was under that bed the entire time in the OR during the C-section. It was crazy. And
That's
she like
awesome.
after the C-section ended, she got out, and they're like, "You rode the bed." It was like this like passage, rite of passage for the residents.
It's like the OB equivalent to like riding the bed and doing compressions. Like
yes, exactly. Yes, let's not do that on this podcast for this patient.
Yeah, so that's not the case with this patient. That would be a different story.
Yes.
But yeah, that would be elevate the presenting part, get a C-section going.
Right.
And like he said, like you're gonna do this the whole time, like into the OR.
So you may want to get an assistant to do that for
Yeah.
you, so you're not down there the entire time.
I bet a med student would love this.
Med student would love this experience. They're gonna talk about the rest of their life.
Yeah, for real.
Cool. So we talked about the fetal heart tones. Normal is 110 to 160 or so. The fetal heart monitors and tocodynamic monitoring should be applied. If you don't have that availability, that constant monitoring, you're just going to perform your own spot checks every 5 to 10 minutes as able. So what's the ultimate question here as we wrap this up? Because part one's coming to an end. People are on the edge of their seats. They're like, when can I transfer this patient? Like, when do I not have to deal with any of this stuff? What is the ultimate question?
Is the mother near delivery, or do you have time?
Do you have time to work with?
Do you have time to work with?
And there's like two questions about this that can answer it for you. Question number one is what?
Is the mother voluntarily pushing with her contractions? If so, then she's in the second stage of labor. Her cervix is dilated. She's about to deliver.
Now that can vary. That can vary. It's not like they could deliver in the next 5 minutes, but they could. It's just not a good thing to see.
Yeah, it's different than like feeling the contract. She's feeling the contractions, but she's not like pushing with them, like feeling the need to push.
You're certainly not transferring them at this point.
No. And then the second question is the fetus visible? Is a head coming out of the vagina?
In simplest layman's terms.
What does that mean, Dr. Briggs?
This means that delivery is imminent. There is nothing stopping this. It's within minutes. In fact, the studies have shown the median time is 30 minutes for the second stage of labor in a nulliparous woman. 12 minutes for a multiparous woman. So if the fetus is not visible, the imminent birth is still likely, though, if she wants to bear down and push or states that I can feel the baby coming. It's very subjective. So essentially, if the perineum descends with contractions, you feel if you put your hand in there and you feel the head moving towards you. I mean, this is just all imminent. It's going to happen. This is not a transferred patient. I think we all
literally
can agree.
right there.
It's literally right there. If the contractions are more than 2 minutes apart, there may be time to transport the mother to L&D for delivery in your hospital, obviously, like right upstairs. Sure, that's great. But again, I know a lot of our critical access docs are listening. They're like laughing. They're like, upstairs, this is a 1-floor hospital, baby.
Yeah.
There is a helipad outside, and that is it. So seriously, like you could be alone. I mean, here I'm very fortunate and blessed that I'm at a hospital that we literally, if a patient, we've had it several times. They come in, they're contracting, and OB will come running downstairs and like, we got time to go upstairs. And they rush upstairs, and we're all good and happy. So just keep that in mind. All right. Hey, so we're going to leave everybody on the edge here of their seats. We haven't even talked about how to deliver a baby yet.
Yeah.
We've just talked about all the other nightmare things you got to do beforehand.
But hopefully you feel a little more comfortable with what your next steps would be in this situation. What's the information you actually need to get? What, steps 1, 2, and 3.
Mm-hmm.
And stay
Good luck.
tuned.
What would be awful is someone listens to this podcast trying to stay up to date
And that
then they
happens
go
tomorrow.
into their shift and it happens tomorrow and they haven't listened to part 2. And they tell the I'm sorry, I haven't listened to part 2 of Board Bombs on Precipitous Delivery. I
Let
can
us
ask you
know
all
if
the...
that happens.
Yeah, let
If
us
that
know.
happens to you, send me a tweet. I'll apologize in person.
Yeah, we'll give you a full refund if you're a Rapid Bomb premium subscriber. Seriously, we will. We feel so bad.
Oh, man.
All right. That is it for EM Board Bombs. Again, check out EM Rapid Bombs. That's on our main website. Just go to emboardbombs.com and you'll find the link to EM Rapid Bombs. It's a one-click sign-up process, one-click payment process. Very, very easy to do. Downloads to your podcast app of choice on your smartphone. On all the iPhones, all the Androids, the iAndroids. That is it. Dr. Wasiski-kun, we'll see you next time. Thanks again for joining us for this 2-parter. Oh, we gotta leave a dramatic exit. Will this 24-year-old female deliver in time before Obi gets there?
Does her husband have enough cedar oil to rub on her belly? Find out next time.
Is anyone allowed in the room with her, or will she kick medical personnel out?
Stay tuned.
Stay tuned.